Okay, so back in 2005, Perugini devised this visual scale. It's a 4-point visual scale. We've got grade 0, grade 1, 2, and 3. Grade 1 is mild cardiac uptake, inferior to bone. Grade 2 was described in the original paper as moderate cardiac uptake, accompanied by attenuated bone uptake. And then grade 3 was strong, intense cardiac uptake with mild or absent bone uptake. Okay, so this is a grade 1. So basically your bog standard normal bone scan. And when you do the SPECT CT, there's no specific cardiac uptake. I have to stress that when you're doing a DPD scan and you see a normal bone scan, please, please, please do a SPECT CT. So this is the grade 1 uptake. And you can see here, again, just very low grade uptake. And here on the SPECT CT, you've got this increased tracer uptake in the anticipated position of the cardiac septum. This is probably the most common place that you're going to see the increased uptake in a grade 1 scan. So again, if you're seeing a normalish looking bone scan on your DPD, please do the SPECT CT. The differential of this, and we've got some cases to show that, is basically blood pool uptake, and that can look very, very similar to a grade 1 scan on the whole body. So grade 2, slightly more uptake. In the current guidelines, it's described as equal to or greater than bone, and bone has been taken to be rib. In the original paper, it didn't actually specify, but obviously it's a visual scale and individual interpretation of that may vary. But you can see here we've got a bit more uptake and it's greater than the surrounding rib, okay, in this particular case. Oh, I've gone on, sorry. The grade 2, more uptake than equal to the rib, just slightly more uptake. And you can see here in this grade 2, we've also got a little bit of uptake in the right ventricle. So grade 3 uptake, so relatively intense uptake in the heart, and we're losing the bone uptake. You can see here we've lost the long bones, we've lost the ribs, particularly on the posterior view, and here we've got very intense tracer uptake in the heart. So this is putting all those scans together, and you can see as you go across, we've got increasing cardiac uptake and decreasing bone uptake, and we've lost the long bones here in the grade 3. So as I said before, grade 2 and grade 3, a bit of a spectrum, personal interpretation, sometimes quite difficult to decide, is this really a grade 2 or is this pushing into grade 3 territory? I have to say, in terms of practicalities, it doesn't really make much of a difference whether it's grade 2 or grade 3, so don't sort of get too worried and too hung up about that. The difference is between a grade 1 and a grade 2, and I'll go into that later. So reporting, obviously some tips and guidelines. You're looking to see this cardiac uptake. Look at the SPECT CT. Is it a truly negative scan? Adjust the grayscale, perhaps look at the different projections. You're looking for mural uptake as opposed to that central chamber uptake. The distribution, septal predominance, typically seen in the wild-type ATTRs. In the hereditaries, it's often more concentric, more evenly distributed. Bone uptake, attenuation of long bones, and then you can give your Perugini grading. Soft tissue uptake, you may see that. Sometimes we see visceral uptake, liver and spleen. Characteristic to see uptake over the shoulders, gluteal region in some of the ATTRs. And obviously it is a bone scan, so any unexpected findings, although you often, in like say the grade 3s, see very little bone uptake. And this is probably one of the most important statements of Carol and I's presentation, and that is a negative scan does not exclude cardiac amyloid. And you cannot use the DPD scan to diagnose the type of amyloid. That's our other main message. Okay, so back to Carol.
Great, thank you. So we can use this algorithm to help us and determine who needs a biopsy or not. And so if a patient has heart failure symptoms and they have an echocardiogram or CMR, which is suspicious of cardiac amyloidosis, they should then go on to have a DPD scan. And we can see here that this may be grade 0, grade 1, or grade 2 to 3. At this point, if the patient has a positive scan, they need to go on to have serum immunofixation and urine immunofixation and serum-free light chains. If at this point there is no evidence of a plasma cell dyscrasia, so the serum immunofixation, the urine immunofixation, and the free light chains are all normal, and the scan is grade 2 to 3, then we are going down the right-hand side of this algorithm, and we therefore can confidently say that the patient has ATTR amyloidosis affecting the heart, but only if we've gone through these stages first. And at this stage, we will then go ahead with TTR genotyping to determine whether the patient has wild-type ATTR or variant ATTR amyloidosis. Otherwise, they will be in the rest of the algorithm, and you have to work your way through this side, likely requiring a biopsy. So to hopefully demonstrate this, I'm just going to go through a quick case with you. 63-year-old man who was referred a couple of years ago with an abnormal cardiac MRI, which suggested that the patient may have amyloidosis. He'd been breathless for 6 months, with numbness in his hands and feet for over a year. He had some autonomic neuropathy symptoms, alternating diarrhea and constipation with weight loss and anorexia for a year. He'd had bilateral carpal tunnel surgery a few years before. There was no family history. His parents had died in their mid-70s. So he came to the National Amyloidosis Centre. He had a blood workup. Kidney function was normal. He had an elevated NT-proBNP in keeping with his heart failure symptoms. No paraprotein was detected, the serum-free light chains were normal, and there was no BJP in the urine, so there was no plasma cell dyscrasia. He had an SAP scintigraphy scan, which didn't show any visceral uptake. His ECG showed sinus rhythm with normal-sized complexes. The echocardiogram was characteristic of amyloid with increased wall thickness of 15 millimeters. There was also abnormal strain with that bullseye appearance. His CMR had shown typical changes associated with cardiac amyloidosis, with diffuse transmural late gadolinium enhancement, raised ECV, and was characteristic of amyloid too. He went on to have a DPD scan, and you can see that here. I think we can see clearly that this is grade 3 uptake. We can't see the long bones. And he also had a fat aspirate, which showed ATTR amyloid. Genetic sequencing was performed, and he was heterozygote for the TTR mutation T60A. He went on to have nerve conduction studies, which showed they had polyneuropathy and also bilateral carpal tunnel syndrome. So this gentleman had hereditary ATTR amyloidosis associated with the TTR T60A variant. So going back to our algorithm, we can see that he clearly followed this pattern. He had imaging, echo and CMR that were characteristic. He had a grade 3 DPD scan. He didn't have serum or urine immunofixation evidence of a plasma cell dyscrasia, and the free light chains were normal. And so he's following this part of the algorithm here. He had genotyping and was found to have variant ATTR amyloidosis. So in conclusion, early diagnosis of amyloidosis is essential for patients to gain the most from treatment. A negative DPD scan does not rule out cardiac amyloidosis. They may have AL. A positive DPD scan can be seen in AL, wild-type ATTR, and hereditary ATTR amyloidosis. And clearly a multidisciplinary approach is required for this complex multi-system disease. Thank you.
We haven't quite introduced Dr. Anne-Marie Quigley. She is the most experienced DPD reporter in the UK, if not in Europe. She has done thousands of DPD scans and is an excellent speaker as well. So she'll be presenting some cases, and there'll be a case discussion between the two of them. And I wonder if Professor Wetschlager is joining on Zoom, if possible.
Okay, thank you. I think I got a couple of my slides the wrong way around there. I slipped forward. So anyway, so hopefully in this next part, a little bit more interactive. We're going to go through a series of cases with patients who have cardiac amyloid or suspected cardiac amyloid, describe some of the pitfalls in reporting, and then hopefully relate back how the DPD scan fits into the patient algorithm. We were going to do this as an interactive, everybody on their phones, but when I spoke to the AV guys, they said that it'd take about an extra 15 minutes, and I thought that would start interfering into beer time. So we're just going to do a show of hands, if that's okay. So, case 1, gentleman in his 80s, referred with shortness of breath on examination. Some of those markers were elevated, the pro-BNP, which is a marker of heart failure, characteristic echo, and also cardiac MR, and also had a previous history of carpal tunnel, which is actually very common in our patient group. So, I'm going to read these out, and I'd like you to put a show of hands up. It's the most appropriate, so some may be correct, but I'd like you to choose the most appropriate. It's like going back to those A-level questions again. So, the patient has uptake in the region of the heart. The patient has uptake in the region of the heart, but I'd like to see a SPECT CT. The patient has ATTR cardiac amyloid. So hands up for A. Hands up for B. Yeah. And hands up for C. I'm really glad that nobody's gone for C after what we said. You cannot use the DPD scan in isolation to diagnose ATTR cardiac amyloid. Okay, so this is the SPECT CT. We've got characteristic uptake, predominantly septal predominance, uptake in the right ventricle, but we've also got uptake in the walls of the left ventricle. So, moving on, 3 more questions through 3 more statements. So, statement A, show of hands. The patient has ATTR cardiac amyloid. The patient has tracer uptake in the myocardium. In keeping with the presence of cardiac amyloid, more information is needed to characterize the cardiac amyloid. Okay, we're getting there. Okay, the patient must now have a cardiac biopsy. We all say if it's must, it's got to be wrong. Okay. All right. So, this particular case, so we've got grade 3 uptake. We've got some soft tissue uptake. This is the soft tissue uptake I was referring for. It almost looks like someone sort of smudged the uptake over the shoulders. We've lost some of the pelvic bones here. Strong cardiac uptake. And we often see this sort of characteristic uptake in the lateral abdominal walls. This patient's got the majority of their long bones still visible. Anyway, in this particular case, there were no serum or urinary light chains, so the patient does not have a plasma cell dyscrasia. We sent this patient had genotyping, and no hereditary genotype was found. Okay, so we can say this patient does have, or is likely to have, ATTR cardiac amyloid. So, as Carol has said, you need to exclude the plasma cell dyscrasia to use this. The DPD scan, I can't stress this enough, it's just part of the jigsaw. You cannot use it in isolation. If this particular patient had had positive light chains present, that would be a very different scenario. This patient, about 20% of what you would think is going to be an ATTR patient, they actually have plasma light chains, and we couldn't use this statement then to say that this is definitely wild-type ATTR cardiac amyloid. This patient would have to have a cardiac biopsy. Okay, so this is the consensus paper. I think Carol briefly mentioned. So it's a consensus paper by the great and the good dealing with cardiac amyloid, and they wanted to see how useful a DPD was for reliably diagnosing ATTR amyloid without biopsy. And this is the bottom line from this particular paper. In a patient with heart failure, an echo or a CMR suggestive of amyloid with no plasma cell dyscrasia, a grade 2 or 3 scan is reliably diagnostic of ATTR amyloid. You can't tell whether it's the hereditary or the wild type. That has to come from the genotyping. So just like, Carol, do you want to say anything about this particular patient?
I think that in this particular patient, we're following down the right-hand side of the algorithm as before. So we're confidently able to say that the patient has TTR amyloidosis, and then we just need to genotype them because we had ruled out a plasma cell dyscrasia.
Okay, but like I said, if the patient had had a plasma cell dyscrasia, you don't know whether this is AL amyloid causing the uptake, and we've got particularly strong DPD. Grade 3, we do see that in our AL patients. So the patient would have to have a biopsy. So the next patient is a patient in their 70s. They have minimal neuropathic symptoms, but they do have a strong family history of polyneuropathy and also cardiac amyloid. So this is the DPD scan. Okay, so back to the show of hands. Is this a negative study with no cardiac uptake? Is it a likely negative study, bit of blood pool? Or is this a possible negative study, but I want to see the SPECT-CT? Okay, great. So here's your SPECT-CT. So looking at the SPECT-CT, we're back to hands. Is this blood pool uptake only? Is there low-grade myocardial uptake? And is there, better statement, low-grade myocardial uptake and further investigations, evaluation is needed? That's great. Okay, so we've got slightly atypical, but it's definitely following the outline of where you'd anticipate the myocardium to be, and it's not sort of central chamber left ventricle. So putting it all together, this patient's got very subtle uptake on the whole body scan. You can barely see it. So this is what I'm telling you in terms of you need to do that SPECT-CT in these particular cases. So we've got this subtle uptake on the SPECT-CT. Further information with this particular patient. Plasma cell dyscrasia was excluded, so they don't have AL. The CMR was diagnostic of early cardiac amyloid, and the patient had gene typing, and it was S77Y. And this genotype is typically associated with quite low-grade cardiac uptake. So again, my teaching point, getting a bit like a broken record here. SPECT-CT, especially useful in a normal-looking scan, and the DPD, don't just use it alone. Okay, case 3. This was a patient in his 60s, and he was referred, he had some local investigations for shortness of breath. He was then referred to the amyloidosis centre as having a positive DPD for further evaluation of his cardiac amyloid. So here we can see we've got this uptake in the region of the heart on the whole body scan. So, is this a positive DPD scan, grade 1, 2? Is it a positive scan? The patient has cardiac amyloid, or there's uptake in the region of the heart. I want to see a SPECT CT. Okay. Okay, and this was said SPECT CT. So you can see. So having all seen the SPECT CT, is this myocardial uptake? Is this blood pool uptake? Yeah. And for those who are not sure, okay, yeah. This is blood pool uptake. You can see it's sort of central chamber, and you've got photopenia in the sort of anticipated positions, the walls of the left ventricle. So this particular patient had blood pool uptake only. In the MDT discussion, the patient had an abnormal CMR, but it wasn't typical of cardiac amyloid. There was no hereditary genotype detected and no plasma cell dyscrasia. However, because this particular patient had a slightly abnormal CMR, he did go forward to have a cardiac biopsy, which obviously it's quite sporting endomyocardial biopsy. You know, it's not without risk. So, SPECT CT, useful for deciding where the uptake is. Okay, case 4, you can rest your arms for this one. So it's a patient in their 70s, again, reduced exercise tolerance, abnormal CMR, and you can see this is probably the more typical blood pool uptake, just kind of, you know, sort of pixelated, nothing really. You want to play around with the grayscale, look at the different projections to decide that it really is blood pool uptake. Okay, case 5, a patient in their 50s presented with fatigue and had mild shortness of breath. So here's the DPD scan. Here is the whole body, the SPECT CT. So back to the arms. So response A, no cardiac uptake. No cardiac uptake, the patient does not have cardiac amyloid. Or no cardiac uptake, the patient needs further investigations. Yay, we're getting there. Okay. So this is a patient with a negative DPD scan, grade 0. This is the danger patient. We've got a COR positive for cardiac amyloid. They had wild typing on their genotyping, okay? But this is unlikely to be wild type ATTR. You'd expect if the patient had wild type ATTR to have a grade 2 or 3. We usually see intense with the wild type patients. The hereditaries, you can have this slightly wishy-washy uptake, low grade uptake on the SPECT CT, but with the wild types, it's usually really intense. I don't think we've seen any grade 1 wild types, as far as I'm aware. No, I've not reported one. Okay, so the important teaching point here is that a negative DPD scan does not exclude cardiac amyloid. I don't really want to say anything.
So with this patient, the DPD scan is grade 0, so we can be confident that they don't have ATTR amyloidosis, but as we know, they may well have AL amyloidosis, and if this patient has a characteristic CMR for cardiac amyloidosis, when the heart is involved, we know that the time is of the essence, and they urgently need to have a diagnosis made so that they can start treatment for their AL amyloidosis, because we know that once the heart is involved in AL amyloidosis, then they only have months to live. So it's absolutely paramount that this patient is treated as urgently as possible to allow them to respond to treatment and potentially have a good outcome.
Yeah, so plasma cell dyscrasia is AL until proven otherwise in a patient with a positive CMR. Okay, this is another one of our patients. This patient had polyneuropathy, early symptoms, and they also had mild shortness of breath on exertion. They also had history suggestive of carpal tunnel. A lot of our patients have carpal tunnel-like symptoms or proven carpal tunnel, previous surgery. But this patient also had a very strong family history and basically wanted to know that if he was a carrier of this gene. Okay, so looking at the DPD scan, the patient has ATTR cardiac amyloid. Can I convince someone? No? Okay. There's grade 2 increased uptake in the region of the heart. I would like to confirm on SPECT-CT. Possibly don't need it, but, you know, with this type, or not sure. Okay. So here is the SPECT-CT. So the patient has no plasma cell dyscrasia. The echo was characteristic for cardiac amyloid. So this patient has cardiac amyloid. This patient has cardiac amyloid, likely ATTR. This patient is likely to have ATTR cardiac amyloid. Gene typing is required to distinguish between wild type or hereditary variant. Yeah. So all these statements are true, but this, you know, you can say it's likely going to be ATTR because he doesn't have a plasma cell dyscrasia, but you can't take the ATTR amyloid any further than that. You need to distinguish with the genotyping. Okay, this patient went on to participate in one of our trials, and you can see here this was the pre-trial scan, and this is the post-trial scan, and you've got a reduction of uptake. So the uptake's on 2, 3. We've gone to a sort of a low grade 2, bordering on a 1. Okay, and this patient had the T60A mutation. So it's just a nice case of showing the reduction in tracer uptake. In terms of using the DPD scan to track progress, I don't think we've certainly in the literature, it's not really conclusive yet whether you can use DPD. For example, we've had patients with reduced amount of DPD uptake and they're clinically getting worse and their CMR's getting worse. It would appear that CMR's probably better at tracking amyloid burden. Okay, case 7. A patient referred with incidental amyloid on their colonic polyps and also had a decline in exercise tolerance. Again, it's unlikely to be the wild type ATTR as we've got no cardiac uptake. Could possibly be hereditary, but definitely, you know, pretty certain it's not going to be the wild type, particularly patients sort of in his 60s as well. So further investigations, myeloma was diagnosed. So this patient has a plasma cell dyscrasia. Amyloid is likely. We would do genotyping just to exclude one of those hereditary variants that sometimes when the patients are younger, they can often have a negative scan, and when they're older, we can get positive DPDs, so we do them sort of kind of like every 2 years or so. So this is another one of those patients, AL amyloid diagnosed, and the patient was referred to chemotherapy. So these patients can have a really poor outlook and can be dead within 3 months if they don't start treatment. So teaching points, SPECT-CT required. We've got so much soft tissue uptake, it's actually really difficult to see what's going on in this heart. Here, a negative scan doesn't exclude cardiac amyloid, and you can't use the DPD in isolation. Okay, this is the final case. So this is one of our patients who had a DPD scan back in 2011, and you can see here that we've got quite marked uptake. This is his scan in 2024. No cardiac uptake. More clinical information on this patient. No plasma cell dyscrasia, no hereditary genotype detected, and in the echo from 2011, cardiac amyloid was diagnosed. The patient at this time, back in 2011, had severe heart failure, but is currently well. Sorry. Okay, so here are your options. The patient had a grade 3 DPD scan back in 2011. In 2011, likely ATTR cardiac amyloid of the wild type. The patient now has no cardiac uptake, or statement 3. Option D, all 3 statements are true. Yeah, all these statements are true. Okay, so in case 8, this is a patient who had wild-type cardiac amyloid. He was in his 50s back then and actually had a cardiac transplant. So that accounts for we haven't just, given him some magic drug. The patient has had a transplant, okay? And what we can see from the DPD scan, no uptake in the heart. We've got lots of soft tissue uptake, which you can see on the whole body study. So as far as we can tell, this patient has no recurrence of the cardiac amyloid, certainly scintigraphically on the DPD scan, and his echo was also negative, so no evidence of recurrence. Okay, so in summary, the DPD scan is a useful and non-invasive way of assessing for the presence of cardiac amyloid. A negative scan doesn't, you're going to sick of hearing me say this, does not exclude cardiac amyloid. The SPECT-CT is vital, particularly in these 3 scenarios, distinguishing blood pool from true cardiac uptake, visualizing the heart when you've got excessive soft tissue uptake, like some of those patients I showed, and identifying the subtle grade 1 uptake, those early hereditaries, for example. DPD alone cannot be used to distinguish between AL and ATTR, or even other amyloid types. It's just part of the jigsaw. You need the rest of the clinical information. And then the statement from that 2016 consensus, if the patient has grade 2 or 3 uptake, a diagnosis of ATTR cardiac amyloid is likely in the presence of a positive echo or CMR and the absence of a plasma cell dyscrasia. And the significance of change in tracer uptake has yet to be established. So I'd just like to say thank you. I'd like to say thank you to David Hutt, who's our senior technologist in the National Amyloidosis Centre, my NEC colleagues, my nuclear medicine team at the Royal Free, and all of our lovely patients at the NEC. And this is the reference for the guidelines that have been put together and published in April. It kind of tells you how to do it, all the tracer details, all the scanning sort of, how to actually perform the scan, and basically summarise what we've said today.